Yeah, Dr. Rosil, you can switch on the video now. We are live on the YouTube. We'll be starting the program now. Yes. So good morning all. Welcome back to Saturday Club morning meeting. And today we have very interesting topic and a new guest speaker for us. Very happy to welcome Dr. Rosil Gandhi, who is an interventional radiologist from Ahmedabad. Welcome Dr. Rosil for accepting our invitation. And I must thank Dr. Chetan Sir for getting this to us. To introduce Dr. Rosil, his academic qualifications are DMRD, DNB, and fellowship in interventional radiology. He has 10 publications to his credit, several presentations at national conferences. His areas of interest are GI interventions and percutaneous interventions. He has received many awards and achievements for poster presentations at various conferences. He was first in Gujarat to start hip transjugular liver biopsy and many other procedures to his credit. Today he is going to talk to us about newer treatments in interventional radiology. So over to you, Dr. Rosil. You can start sharing the screen and start the talk for about 40-45 minutes, and then we can have discussion for 10-15 minutes. So over to you, Dr. Rosil.
Good morning, everybody.
Good morning.
I'm thankful to Chetan sir and Satish sir for inviting me. I'm honored actually. I will talk about my branch and what are newer modalities we have in helping patients management. So newer treatments, basically intervention radiology is a type of therapeutic radiology. It is divided into two parts, non-vascular and vascular. In vascular part, we do embolizations or recanalization. Embolization is closing of a vessel, whether it is bleeding, whether it is because of the tumor, whether it is AV malformation. Revascularization is we open the vessel, whether it is diabetic foot or it is closed because of the smoking. So we can open basically any vessel. We don't touch heart and we close any vessel that is bleeding. In non-vascular part, we do true cut biopsies, ultrasound or CT guided diagnostic biopsies. Then what we do is we aspirate abscesses, insert percutaneous drains. Even in post-op collections, we insert percutaneous drains. And then we do RF ablations, radio frequency ablations of tumor. So these are the things we all routinely do, but I will talk about newer modalities. So coming to embolization, we do bronchial artery embolization for hemoptysis. Abdominal arteries like gastroduodenal, splenic artery embolizations for GI bleeds. Sometimes in pancreatitis, we find pseudoaneurysms, we embolize them. Then there is radioembolization, transarterial radioembolization. It is also called selective intraarterial radiotherapy. We embolize advanced malignancies of liver. This is a liver-directed therapy. We embolize advanced malignancies of liver with injecting radioactive particles inside the hepatic artery. So that is transarterial radioembolization. For females suffering from menorrhagia or dysmenorrhea or large fibroids, we do a uterine artery embolization for symptomatic management. The menorrhagia reduces. So if patient doesn't want hysterectomy, then uterine artery embolization is a good option. We do lymphangiographies. Lymphangiographies is needed when there is chylous ascites or chylous effusions in the post-operative period, like a pelvic surgery, Wardheim's hysterectomy. There are chances of lymphatic leak. Also in retroperitoneal dissection, esophagectomies, chyle leak is a known complication. So we do lymphangiography and embolization of the leaking lymphatic duct. Then embolization for, this is a very new treatment we have started. Embolization for knee pain, osteoarthritis, heel pain, tennis elbow and frozen shoulder. Not all patients can be done, but there are few indications where these patients match for embolization treatment. Then we see patients with cirrhosis, with refractory ascites or refractory variceal bleeding. Two tips, that is palliative treatment. We know that when this end-stage liver disease, liver transplant is the best option. But for palliation, patients who don't want to undergo transplant, transjugular intrahepatic portosystemic shunt can be done. We do post-transplant interventions and transjugular liver biopsies, and also vascular foreign bodies. When there is a wire inside the IVC, there is a new resident inserting a central line and he forgets the wire. So IVC filter and vascular foreign body retrieval. I have not put much theory, they are just cases and examples, and we'll discuss it. You can ask me any questions afterward. Young male, post-traumatic acute pancreatitis, there was a blunt vehicular injury, had bilateral flank collections, typical in acute severe pancreatitis. PCD was inserted, but had hematemesis on 3rd month. CT showed a pseudoaneurysm of the gastroduodenal artery, which is supplying the duodenum and the head of pancreas. So this is a angiogram of celiac artery, this one. This is the left hepatic, this is the right hepatic, and these are catheter inserted from the femoral root. This is the common hepatic artery. This is the surgical drain, which is inside. Sorry, this is the Ryle's tube, which is inside. This is the superior mesenteric artery angiogram, and this is the round pseudoaneurysm with the blue arrow. This is the gastroduodenal artery. Gastroduodenal artery is filling from the SMA collateral, mesenteric artery collaterals. So this is what is done. We have placed coils and glue. So this is embolization of the pseudoaneurysm. Very risky procedure by surgery, but by minimally invasive angiographic route. It is very safe and highly successful. So we have embolized the collateral as well as the pseudoaneurysm, and thus we have saved the patient from bleeding. Next case. Middle-aged male, history of old cocks, presented with recurrent massive hemoptysis. CT showed a pseudoaneurysm in the lung. Bronchial arteries, they are systemic, bronchial artery is the systemic supply to the lung. Generally, it supplies 1% of the total lung supply of the blood, but it is high pressure. The pressure is much higher than the pulmonary arteries. So generally, hemoptysis, the bleeding occurs from the bronchial artery source. When there is damage to the lung because of the cocks, because of the fibrosis, because of the bronchiectasis, there is hypertrophy of the bronchial artery, and this leads to bleeding. This is typical pseudoaneurysm of the bronchial artery. So this is the pseudoaneurysm, and that is which is bleeding. So this is pre-embolization and post-embolization. We are not seeing any pseudoaneurysm here, which was seen here. So this was embolized, and the patient is free from bleeding as of now. Coming to liver part, is a patient with a known case of diabetes, 65-year, presented with anal fissure treatment. Ultrasound showed, incidentally, ultrasound was done prior to treatment, showed a liver tumor with high alpha-fetoprotein. So alpha-fetoprotein above 400, it is diagnostic of hepatocellular carcinoma. This was 6 by 5 centimeter liver tumor, which was arterially enhancing and venous, showing venous washout. So this is typical HCC, no need for biopsy. because it is arterially enhancing venous washout and AFP is more than 400. So best treatment for hepatocellular carcinoma is surgery. But when patient tumor is not resectable, or the liver is not good for resection, or patient is not medically fit for resection, transarterial chemoembolization is done, because TACE is the best palliative treatment. Once the patient is out of curative treatment, patient goes for palliative treatment. And TACE as of now is the best palliative treatment for HCC, hepatocellular carcinoma. It gives survival benefit of more than 6 months to 2 years. So this is again celiac angiogram. This is the splenic artery. This is the left gastric artery. This is the common hepatic artery. This is left, middle and right hepatic artery. This tumor was in segment 6. So we went in the right hepatic artery. And this is the tumor supply. So with our microcatheter from the femoral artery, we have went in the only the tumor feeding supply. So injection of drug is generally done only in the tumor feeding arteries, not in rest of the liver. So the maximum dose of drug goes to the tumor and there is less side effects, less toxicity. So we can see that drug is, this is the black drug that is filled in the tumor, and this is post embolization. No hypervascularity is seen. We don't see hypervascularity after embolization. This is the pre-embolization vascularity. This is post-embolization. This is pre-procedure CT showing tumor thrombus in the posterior branch and also the tumor. This is post-embolization, filling of the tumor with the drug, and this suggestive of good response. So this is how chemoembolization is done. This is called transarterial chemoembolization for HCC. It can also be done for neuroendocrine tumors and metastatic colorectal tumors, but not responding to medical management, because colorectal mets generally respond to chemotherapies. So TACE is not the first line treatment for metastatic colorectal malignancy. In this patient, doxorubicin, cisplatin and lipiodol was injected in the segmental branch. After 24 months, AFP was less than 10. This patient died after 5 to 6 years, but not because of malignancy, because of other medical issues. This similar another case, this is liver angiography. This is the gastroduodenal artery. This is the left hepatic, middle hepatic and right hepatic artery. You see this black blush, that is the tumor. This is the diaphragm. So you can see multiple black, the white arrows, they are small tumors, and also the blue arrow is the large tumor. So this is multifocal HCC, multifocal hepatocellular carcinoma. Of course, surgery is not possible, and even in multifocal cases, liver transplant is generally not indicated. So we embolize it. This is pre-embolization on the left side and post-embolization on the right side. You don't see tumor vascularity after injection of embolizing agents and chemotherapeutic agents. Very good feeling of chemotherapeutic agent inside the tumor. So this is the MRI of that patient, same patient, but not all lesions are seen on MRI. Small lesions are better seen on angiography sometimes. Another case, similar large tumor, right lobe of liver. You see the blush, there are too much abnormal arteries which is supplying, and this is post-embolization, no supply to the tumor. So this is how we palliate the hepatocellular carcinomas, the primary liver malignancies. The TACE, the drug, more of the drug goes inside the liver. In chemotherapy, drug goes everywhere. In TACE, more of the drug goes inside the liver. As I told, radioembolization, TACE, we embolize the artery. You know that hepatic artery branch we have embolized. So there are some changes in the liver enzymes. There is chances of liver decompensation. That is around 2 to 5%. But when the portal vein is also thrombosed because of HCC, TACE cannot be done. TACE is contraindicated because you can't close the artery when there is already thrombus in the portal vein. There would be acute liver failure. So in this type of cases, radioembolization is done because we inject radioactive agents inside the liver tumor. Injecting the radioactive agent inside the liver tumor, it helps because it causes necrosis of the tumor. There is no closing. We are not closing the parent vessel. They are very small, tiny radioactive particles of 30 to 50 micron, and they don't occlude the parent artery. So there are no chances of liver damage. Only the tumor gets damaged. Is a patient with large right lobe HCC with main right and left portal vein thrombosis on medical management of lenvatinib. There was no extrahepatic disease on PET CT. So this patient was taken for transarterial radioembolization. This is a large tumor with main portal vein thrombosis. This is the MRI, axial, contrast. This is the PET CT image, and this is the CT image. It shows FDG avidity on PET CT and heterogeneous contrast enhancement on MRI. This is the right hepatic artery. Our catheter is in the right hepatic artery. This is the microcatheter in the tumor feeding artery. This is the tumor feeding artery. We have super selectively cannulated it with a microcatheter. This is how we are injecting radioembolization. The drug generally is costly. It comes from Canada after we measure the volume of the tumor on CT scans. After measuring the volume, we calculate the dose, and the dose comes from Canada. This is yttrium 90 drug, and it emits gamma rays. So 2 to 5 millimeter of tissue surrounding the particle, it gets treated. So this is the kit, and it houses the radioactive particle, and this is how we inject. So this was the first case I had done 1 or 2 months back. This is the first case of Gujarat. Again, this is indicated for HCC, neuroendocrine tumors, colorectal mets not responding to chemotherapies with portal vein thrombosis, large tumors. This is the only therapy that can cause atrophy of the disease. Okay. Another case, 52-year-old male post Whipple surgery. We know Whipple surgery is done in CA head of pancreas when it is not advanced. But Whipple surgery has its own set of complications, and they are known. They are not common. They are rare, but they are known. This patient presented with bleed from drain on day 11 of Whipple surgery. CT showed a GDA stump bleed. So where the surgeons closed the GDA from the origin of the common hepatic artery, there was bleed from that side. So this is the area of bleed. This is the common hepatic artery. This is the left hepatic artery, middle hepatic artery, and this is the area of bleed. This is the bleed, and we have placed the stent. This is the stent graft which is placed. Routine stents cannot be placed. They are porous. The bleed will continue if we place the routine stents. These are the stent grafts which are placed inside so that it has a covering on the stent and it stops the bleeding. So here bleeding has stopped. This is the plastic stent inside. As I told, we stopped bleeding from almost all the arteries. This was a case of aortic aneurysm, incidentally detected with a small left hemothorax. Patient had a known case of soft tissue sarcoma of thigh with mets everywhere, presented with left-sided chest pain. CT showed a small aneurysm in the distal thoracic thoracic aorta, many 5 to 6 centimeters after the origin of left subclavian. You can see the small pseudoaneurysm, and this is the surrounding tumor. The white arrow shows the surrounding tumor, and small pseudoaneurysm is seen. This is angiogram showing the pseudoaneurysm, and this is after stent placement. So this is called TEVAR, thoracic endovascular aortic repair. We inserted 22 French system which releases this 30 mm stent. So the stent diameter is commonly from 24 to 36 mm, and they are also covered grafts. So basically they take the shape of aorta and close the aneurysm. So we know that we have repaired the aneurysm and there is no chance of bleeding now. This is post stenting CT. You see how the stent looks on the axial scan. And this is how stent looks in the reconstruction. There is no feeling of pseudoaneurysm now. So this was a successful TEVAR. Coming to a common problem, 43-year-old female presented with menorrhagia and pressure symptoms. Ultrasound showed a large uterus with multiple fibroids. She had completed her family, so option was hysterectomy, which has obviously very good results, 100% success rates, because menorrhagia stops, there is no uterus. But if patients want to undergo non-invasive or minimally invasive treatment, we do uterine artery embolization. We do an angiography of the uterus, and we close both the uterine arteries. So success rate is not as good as hysterectomy, but it is still above 90%. But this is minimally invasive and patient can retain uterus. So they don't want, if they don't want to undergo surgery, this is a very good option. We inject small particle agents which goes inside the hypervascularity of the fibroids and close it. So after it closes, the fibroid becomes necrose and the bleeding stops immediately. And the same thing we do in postpartum hemorrhage, in uterine AV malformation, and in advanced malignancies which are not operable of uterus with PV bleed. We do embolization. So this is an aortic angiogram. Both the uterine, you see the convoluted arteries. Both the convoluted arteries are uterine arteries. That is typical anatomy of the uterine artery. They are convoluted. And we go selectively. We don't embolize the whole internal ilia. We go selectively. This is the right uterine artery. This is the left uterine artery. We go selectively, we embolize them, and this is the aortic angiogram after embolization. You don't see convoluted arteries. Both the uterine arteries are showing no flow. So patient had immediate relief of bleeding symptoms and also pain, but pressure symptoms takes time because once the fibroid get necrose, it takes time for the body to absorb them, and pressure symptoms get relieved in few months. Indications: menorrhagia, large fibroids, adenomyosis, uterine AVM, ruptured choriocarcinoma, postpartum hemorrhage. This was a young patient presented with menorrhagia after DNC, ultrasound and CT MRI showed an AV malformation. So this is right uterine artery, this is left uterine artery, this is small AV malformation after DNC. This is a known complication after DNE or DNC. And these below images are the post-embolization. We embolize the AVM and then there is no bleeding. Coming to the newer musculoskeletal embolization, as I mentioned, we embolize the patients with heel pain, we embolize the patients with knee pain. So this was a 44-year-old female, pain in heel since 18 months and hampering day-to-day activities, not relieved with traditional treatments, physiotherapy, and NSAIDs. So what we do is we do an angiography. Generally, heel pain is because of plantar fasciitis. That is the most common, and sometimes tendoaculitis is also there, but tendoaculitis does not cause heel pain. They cause posterior ankle pain. So we do the same thing everywhere. We embolize it. There is no rocket science. This is the hypervascular blush of the plantar fascia. This is inflammation. You can see, you don't see blush here, here, but there is blush here. So this is a hypervascular blush of plantar fasciitis. Inflammation is itis, is inflammation, and it causes hypervascularity. And hypervascularity irritates the tendons. Once it irritates the tendons, there is irritation of the sensory nerve endings. So if we embolize it, the irritation goes away, the hypervascular blush stops, and the pain stops. So this is post-embolization. So now we have done more than 13-14 cases of plantar fasciitis embolization. Almost all the patients have very good results, barring one. So more than 90% success rates in helping in pain relief. So because of the angiography, these patients, we immobilize them for 6 hours because of our femoral puncture. And next day, routine and walking and light exercise activities are allowed. Coming to knee pain, this patient had bilateral knee pain and heel pain, restricting daily activities. Medial tenderness was present. X-ray showed a grade 3 osteoarthritis. There is still some knee joint space in the medially, reduced, but still some there. So we do a knee genicular artery embolization for patients with osteoarthritis. They should not be severe. Grade 4, when the bone touches each other, in this type of cases, the results are not good. But in early cases or moderate cases, the results are good. We help them in achieving pain relief up to 60 to 80, 90%. And this pain relief by papers, they remain for 3 to 5 years. So we can delay the knee replacement. Or in some cases, if the patient do not want, then they are happy with this pain relief and they don't undergo knee replacement. First case we had done in September 2020, and we decide the case after examining the patient, taking the WOMAC score. This is the left descending genicular artery. You can see the blush at the knee joint, at the medially. This is an abnormal blush, and we embolize it. So we selectively cannulate each and every. This is the inferior genicular artery. This is the inframedial artery. This is the supralateral artery. So we cannulate each and every artery and embolize these blushes. And after embolization, generally the results are very good. And so now we have done many cases, so we know which cases to select. The patients with rest pain, medial knee pain, stiffness improves better. But some patients who generally have just pain on staircase climbing, they don't, we can't help them much. But the rest pain and the inflammatory pain goes away. So these are basically a safe pinhole technique and angiographic method, minimal complications, essentially a daycare procedure or just a one-day procedure with no limit of, no need to undergo physiotherapy or anything. They can go for routine activities the next day. So out of our 198 patients, 15 patients had recurrence of symptoms. So more than 90% success rates. And first case was done in September 2020. So nearly 2 years in few months. So going to publish our experience. These are papers of genicular artery embolization. First paper in 2014 by the Japanese group. Embolization doesn't cause knee necrosis. Even after embolization, if it has failed, TKR can be done. And we only embolize the blush, the parent artery remains patent. So there is no necrosis of the joint. Basically, we only treat the synovitis part. So this is various papers in the international journals for the same. And there was a study where MRI was done after embolization, 1 year, 2 years, but there was no necrosis of the bone. There was just absence of synovial vascularity. So basically, we are embolizing the synovium. So there are many papers which shows 3 to 5 years pain relief of 70 to 80%. Similarly, technique which we use for genicular artery and plantar fasciitis embolization, same thing is used for frozen shoulder. Frozen shoulder, we can't improve the movement, but we can help in pain relief. We embolize 3 to 4 branches of the subclavian artery, like thoracoacromial, suprascapular, coracoid, and anterior and posterior circumflex humeral. and we embolize the blush. You can see the black blushes seen here. They are not seen in this. So this is pre and post frozen shoulder embolization. Coming to other cases, this is a lady presented with face, neck, and bilateral upper limb severe edema since a month with difficulty of breathing. CT showed a large right lung mass invading mediastinum and involvement of superior vena cava. So this was a SVC obstruction, SVC syndrome, where large lung mass has invaded mediastinum and causing obstruction of SVC. So there was upper limb edema and facial edema, difficulty in breathing because of it. So this is pre-stenting occlusion of SVC, superior vena cava. You can see all types of chest wall collaterals, posterior chest wall, anterior chest wall collaterals, dilated subclavian vein. These are the valves in the subclavian vein. This is post-stenting. The flow goes directly in the heart. Even the stent is compressed by the tumor, but it is patent. Flows goes directly into the heart and there are no filling of collaterals. So you know that you are successful. And the facial edema and breathing difficulty goes in 24 hours. So this is indicated in patients with advanced malignancies. We know survival is less than 6 months. This is just for palliation of symptoms. As I told, non-vascular part, we do biopsies. I will just show some difficult biopsies. What is the smallest nodule where we can do biopsies? We have done biopsy up to 7 mm in size lesion. This was non-malignant. This was a patient with a breast lesion, with a lung lesion. Surgeon wanted to know whether the lung lesion is malignant or not. So whether he can go for surgery or not. So this patient was had non-malignant lung nodule and she underwent breast surgery. Orbital mass, when the mass is deeper, for biopsy, for histopathological diagnosis, ophthalmologist would need a GA. But this type of CT guided biopsies can be done under local easily and would give enough tissue. This is a true cut biopsy. This was a rhabdomyosarcoma. Biopsy of cervical vertebra, biopsy of lumbar vertebra and dorsal vertebra relatively easy. Biopsy of cervical vertebra are difficult because they involve sometimes both the transverse process have vertebral artery and sometimes these lesions involve the transverse process, pedicle and also the body. So how to do a biopsy of C2 vertebra? C1, C2 vertebra, the biopsies are challenging. This was a young male with neck pain and difficulty in neck rotation. CT-MR showed a C2 lesion. This is a lesion in the C2 vertebra, also compressing the cord at that level. This is the lesion of the C2 vertebral body. So the easiest way is go from anterior root through the mouth. And this is how we go. This is the CT showing we have inserted needle from the mouth under general anesthesia. So this is how the mouth is retracted, patient is intubated, and we insert needle directly from the mouth into the vertebra under CT guidance, obviously. And this is we have taken the cut, and this was a giant cell tumor of C2 vertebra. So these are rare biopsies we do sometimes, but when there is no lesion anywhere else and we need a diagnosis, we have to do this kind of biopsies. They are safe. They are very well documented in the literature. Liver biopsy is very common. We need liver biopsies for liver lesions. Also for benign liver disease, where there is fatty liver, whether there is hepatitis, the enzymes are not going down, when there is ascites. So liver biopsies needs to be done. But when there is high bilirubin, when there is ascites, when the INR is altered, platelets are low, percutaneous liver biopsies become very risky. In this type of patients, we do transjugular liver biopsy. We go from the IJV into the SVC, superior vena cava, from SVC into the inferior vena cava, from inferior vena cava into the right hepatic vein. And from right hepatic vein, we take the sample of right lobe of liver. So even if there is bleeding, it goes into the hepatic vein. So the chances of bleeding are very less. Chances of bleeding outside liver are very less than 2 to 5%. So this is a safe biopsy. We insert needle from the neck go into the hepatic veins. So this is our needle or assembly into the hepatic vein, and we are taking true cut from the hepatic vein. This was a patient with autoimmune hepatitis on histopathology. After biopsy, we take gram whether there is bleeding or not. If there is any bleeding, we immediately embolize it. So this is how biopsy is done. You see, this is the liver, lung, this is our catheter in the right hepatic vein. Now my needle would be coming through the catheter. This is basically a sheath inside the right hepatic vein. And this is how we have taken the cut. We have taken the cut outside the sheath and we retrieve the needle. So this is how a true cut biopsy is done from the transjugular route. This is a very safe method in benign liver disease, in diffuse liver disease, where the coagulation parameters are altered and there is ascites. So this is a safe technique. Sometimes in cirrhotic, we find isolated gastric varices, not esophageal varices. Esophageal varices are easily banded by the endoscopy route. Large gastric varices. This was a patient with young lady with Wilson's disease. Wilson's disease where there is abnormal copper deposition in the liver, and these are large gastric varices. Isolated gastric varices we treat. We go from the femoral route, but we can't go into the gastric varices directly. If there is a lino-renal shunt on CT, there is communication between the splenic vein and renal vein on CT. We go through the shunt into the gastric varices and we embolize them with sclerosing agents. So this is our balloon inside the lino-renal shunt, so that whatever we are injecting do not come out into the systemic circulation. And after inflating the balloon, we inject sclerosing agents through the lumen of the balloon, and this is how it fills almost all the varices, and this is how we treat isolated large gastric varices. This is called BRTO, balloon occluded retrograde transvenous embolization of the varices. Very common problem, varicocele. Varicocele is very easily treated by surgeons under local anesthesia, a safe and easy surgery. But there are some patients who do not want surgery or dressing at that scrotal area. They come for embolization of varicocele. So how varicocele, what is the problem? What is the pathology? There is a reflux of blood into the internal spermatic vein on the left side commonly, which opens in the left renal vein. So ideally, if we inject contrast in the internal spermatic vein, it should go towards the left renal vein and towards the heart. That's how the blood in veins go. But here it is going away from the heart into towards the spermatic cord, towards the testis. In the scrotum. So the scrotal veins are filled up, the varicocele is filled up. And this is after embolization. We have embolized the entire vein, so now there is no reflux. We embolize the entire vein with coils, and now there is no reflux, and this is how we treat varicocele. Okay. So this is a very rare complication of PICC line, peripherally inserted central lines. Central catheters, common for patients with long-term antibiotics or sometimes in chemotherapy setting. PICC lines are needed, but if they are not fixed properly, they migrate into the lungs. So this is a picture of migrated PICC lines. This is a migrated PICC line with both the ends in the, this is the end in the left pulmonary artery, this is the end in the right pulmonary artery, and the main body is in the right atrium and the ventricle. Because of the suction by the heart in the venous system, the PICC lines migrate, so they should be fixed properly. And this is how I removed it with a catheter. I straightened it in the inferior vena cava. And this is how the line, this is the line which is straightened with our catheter here. And we are pulling it towards the femoral side. We are pulling it and it is coming out. And then this is the line. Then we are capturing it with a snare. This is the snare. This is the intravascular snare. This is how we capture any foreign body in the vascular system, like wires or PICC lines. So this is we have captured, and we are pulling it now. So this is the line, and we are pulling it. You see this line? Pulling it gradually, slowly we are pulling it out of the, through the femoral root. So this is the PICC line. So this is post after removal of the line. Very rarely we see cases of retinoblastomas. So retinoblastomas occur in patients less than 10 years. This is a pediatric age group tumor. And treatment is removal of eye. So a child with eye removal is a very sad thing. In some cases, there are bilateral retinoblastomas. So to remove both the eyes should look like a crime. But for tumors, we have to remove. They are the malignant tumors. In this type of cases, in some fraction of some cases, what we can do, we go directly in the ophthalmic artery from the femoral root. You know, we have got almost in all arteries now. So ophthalmic artery, we go directly and inject melphalan, that is a chemotherapeutic agent, 5 milligram of melphalan. We go super selectively. This is the ophthalmic artery from where the central retinal artery arises, and we inject chemotherapeutic agent. So this is called OAIC, ophthalmic artery intraarterial chemoinfusion. This helps when the patients are not responding to CT and RT, and when you don't want to remove the eye. This gives very good results. This is called ophthalmic artery chemoinfusion. Intraocular retinoblastoma with no extraocular involvement, that is the indication. Bilateral blastomas, 4 and 5 grade retinoblastoma, and failed primary treatment. Next case, I talked about chylous ascites, chylous effusions after surgery. This was a young female, D12 fracture, traumatic, multiple pelvic bone fracture, lung contusions, liver injury. Gradually in 7 to 10 days, she recovered. But from the ICD in the right lung, the chylous effusion started coming. Chylous fluid started, and it was around 500 to 1 liter every day. So gradually she was losing weight and failure to thrive. So we did a lymphangiography. I have showed you angiographies. Now this is lymphangiography. How we do? We inject lipiodol, that is a poppy seed oil, that is a fatty emulsion oil, that is radiotherapeutic, it is radio opaque. This is how the lymph moves in the body. This is how slowly the lymph moves. This is an internal iliac lymphatic chain. This is a lymphatic duct. So we puncture the inguinal node and inject this dye, that is lipiodol. And we see, when we try to see from where the leak is, this is an external iliac chain lymphatic duct. we are injecting from the slowly from the inguinal node. This is the inguinal node, and this is how lymphatic duct lipidol is moving. The contrast is moving. So from the iliac chain, it goes into the para-aortic chain, retroperitoneum. Then it goes in the sac of the abdomen, that is cisterna chyli. And from cisterna chyli, thoracic duct is formed. So we embolize in case of chylous ascites, we embolize the cisterna chyli. In case of chylous effusion, we embolize the thoracic duct. This is the thoracic duct. This is the lower thoracic duct. And our dye is playing in the effusion. You see this dye, which is playing in the effusion around the heart also. So we know from where the leak is. Leak is here. There is no continuity of the thoracic duct seen, and this is the leak. Then we puncture directly from anteriorly up to the retroperitoneum with a needle. This is the cisterna chyli, and this is the lower thoracic duct. We insert a needle and insert a wire through the needle. After inserting wire, we inject glue and we embolize it. So this is our wire, and this is where the leak is. This is the lower thoracic duct at the level of D11 vertebra. And then we have embolized with glue. This patient had no effusion after 3 days of embolization and was able to discharge it properly. Last, this is contrast ultrasound. This is not new. This is since 10-12 years in patients with CKD. When we want to evaluate a liver lesion, we can't do a contrast CT or a contrast MRI. But contrast sonoview, that is a contrast ultrasound image, ultrasound contrast, it can be injected and it is metabolized by the lungs. So there is no renal excretion. So this is a hypervascular tumor in the liver, that is a hepatocellular carcinoma. This is ascites, it is looking black, there is no contrast going. So this is very much real-time contrast enhanced ultrasound. We ablate the lesion and we also see post-ablation how it looks. This is all microbubbles with hexafluoride, sulfur hexafluoride, and they become hyperechoic on ultrasound and can be easily seen. The arterial side is also seen and the venous side is also seen. Thank you. I hope I have not bored you all.
Not at all, Dr. Rosil. It was wonderful. I'm a pediatrician, but still I can appreciate the kind of thing that you are doing is simply amazing. You can stop the screen sharing so that we can have a discussion.
Yes, sir. Yes, sir.
So it was awful amazing, actually. A very revealing kind of presentation for people like me. And I have a couple of questions, and then we can invite the audience to ask questions.
Yes.
My first question is about pediatric. Do you do interventional radiology in pediatric? Any situations where you can step in?
Yes, we do some interventions in pediatric, right from the liver biopsies, liver abscesses, aspirations. Then I have done AV malformation embolizations, that is routine, and osteomas in orthopedic practice. Pain, they are the benign small tumors in the femoral bone or any bone, and we do RF ablations. I have also done a few embolizations of bleeds. And also one patient was of EHPVO, extrahepatic portal vein obstruction, and presented with massive hematemesis. She was a 9-year-old girl. I had inserted tips, that was a shunt from the portal vein to hepatic vein. So we don't have, as of now, just like foreign countries, we don't have a dedicated pediatric intervention radiologist, but we do pediatric interventions that come to us.
Right. Another question is regarding the teamwork. I mean, you have been reaching out to any part of the body. Now I realize Gujarati ma kehta hai ki jyan na pahunche Ravi, tyan pahunche Kavi. But here Dr. Rosil is reaching out every part of the body. for these vascular things. So my question is, how do you actually decide this thing? Because there will always be some discussion regarding whether to go for radiological intervention or to go for surgery.
Generally, we are not the first point of contact with the patients, except for varicose veins and this uterine artery embolizations. Generally, we are referred cases. Like in abdomen, generally the gastrosurgeons or the gastrophysicians or general surgeon or physicians refer cases to us. And so, like in hemoptysis, we are referred by the pulmonologist that he or she must have done bronchoscopy and evaluated. Also, the CT would have been done. Medically, hemoptysis patient would be medically managed, but failing, not responding properly. So then we are referred cases. So almost, except in few indications, generally we are referred cases. So basically, it's like a teamwork. I give my inputs to the referring physician, and they also give me inputs, and we do this. This is how we do cases.
Thank you. Dr. Chetan is here. Actually, I must thank Dr. Chetan to have brought you here in this club. If Chetan is around, you can make some comments if he wants. Or he has left, I think. Yeah, Chetan is there. Chetan, are you listening?
Yes, yes. Basically, as you rightly said, the Rosil is like a masiha for us physicians or clinicians, because when the problem is, in a clinical setting, torrential bleeding from the hemoptysis or hematemesis or something, and we are against the wall, these are the people who help us. The patient is also in panic. We are also in double panic at that time. And but these are wonderful procedures. I would like to know from you that what is the complication rate, Rosil, and what are the common complications which you encounter during such procedures?
Like in GI bleeds, in patients with hemoptysis, bronchial artery embolization, we explain that our success rates are good, but they are not long-lived, because the damaged lung is already there and it will definitely bleed second time. After few months or after few years, we never know, but they will definitely bleed. So the lobectomy or pulmonectomy is a best procedure. But if there are bilateral bronchiectasis or bilateral disease, it can't be done. So recurrence in bronchial artery embolization. In GI bleed, I have encountered few bowel ischemias because of me doing embolization. Now there was a jejunal or an ileal bleed, and we embolize it. Then there are chances of ischemia in the bowel, and 1 or 2 patients had to undergo surgery for the same. Because of my embolization, there was ischemia that I have encountered.
Dr. Sulin has asked about USG with contrast, and I think you already answered in the chat box.
Yes, so, ultrasound contrast can't be done in every machine. There are some machines which allow contrast ultrasound because they need specific software for detecting the contrast, but it can be done easily.
So we already reached the time limit. So thank you, Dr. Rosil, for joining us.
Thank
Definitely
you, sir.
We'll have you in future meetings also. You have so much huge volume of work that will definitely be benefited if we listen to you more. So thank you very much for joining. And thank you all for joining. We meet next Saturday again, where again we have some offbeat topic and an unknown speaker to us, Dr. Siddharth Srivastava. He will be talking about markers in malignancy, and he is from IIT. So interesting talk awaits us. So let us meet next Saturday again. Thank you all. We end the session here. Thank you. Thank you, Dr. Rodil.